will be a little cumbersome to put a PDF up on the screen. So I have just taken screenshots from the PDF, and it will be like we're reading the PDF together, but I'm just putting them into slides. And that will also help me to present some other examples from other papers that might make the point clearer. That is not in this paper, but so we'll be reading the Impassion 130 paper together. But first, a few disclaimers. I don't mean to say that this is the right approach to reading a paper. This is just the approach that I use and I find helpful. And this is not something that all the points that I'll be discussing today, this is not something that I came up with. I learned from my mentors like Dr. Tanak and Dr. Booth, who are on this call today. So I'm very grateful to them because I have learned by stepping on the shoulders of giants. Whatever I discuss today, if something is not clear, then you can refer to this paper in which we have tried to explain most of the points that I discussed today in further detail and with more examples. So this is just a reference that you can, and this is an open access paper that you can read in your free time if some of the points that we discussed today are not clear. So this is the paper that we are planning to talk about today: atezolizumab and nab-paclitaxel in advanced triple-negative breast cancer, also known as the Impassion 130 trial. So even before you start reading the paper, this is what I do. Even before I start reading a paper, I just want to look like what the source of the funding is, or what the conflict of interest of the authors are, because that will tell me whether to take whatever they have written with a grain of salt, or like that will prepare you for any possible bias that you might encounter while reading the paper. For example, in this case, this was funded by industry. This is an industry-funded trial. And the other thing is I look at the author's affiliation. For example, in this case, there are two authors, as you can see here, who belong to the industry itself. So these are the authors from the industry who are part of the authorship team. And then in the method section, you'll see what the role of the funder, the sponsor was. For this trial, it says the trial sponsor collaborated with an academic committee for trial design and data collection, analysis, and interpretation. I usually don't feel comfortable if I see the word interpretation here, because I think that at least the interpretation part should be independently done by the academic authors, independently of the industry. So if I see that the industry has also been involved in interpretation of the trial, then I feel a little uncomfortable. And as you know, in this trial, it says atezolizumab plus nab-paclitaxel. So there are two different industries, but the nab-paclitaxel industry, which is Celgene, it just provided the drug, and it had no role in trial design. And the other thing that makes me a little uncomfortable is here, when it says all the drafts of the manuscripts were prepared by the authors with editorial assistance from professional medical writers funded by the sponsor. So usually what it means is the draft was prepared by professional writers who were funded by the sponsor, and the authors probably did some editing, but most of the things that you are going to read was written by a professional who was paid from the industry. To give example from other papers, and this is something about typical of journals as well. For example, New England Journal, you can't see author's conflict of interest directly in the paper. You have to go to the supplement and actually download their conflict of interest file, which is not very pleasant. But some other journals, they actually mention conflict of interest at the end, or usually at the end. For example, this is a different trial, Olympiad trial, which was funded by AstraZeneca. And you can see that the conflict of interest, this is the conflict of interest paragraph, and most of the authors you read will have had some conflict of interest from the same company. And some of the authors are actually employees of the same company. So this will tell you that you need to read the paper carefully and not just trust what the conclusion is written in the paper, because those were written by professionals or people with significant conflict of interest. And again, in this Olympiad trial, this is a different paper. Again, it mentions that the company was responsible for interpretation of the data, and the manuscript was written with support from the same industry. So these are the things that I try to read. I try to find these things even before I start reading the paper. Okay, now let's actually go to the paper. So when do you read the abstract? I usually don't read the abstract in the beginning, unless it's a trial that I have already read before and I have already analyzed the trial. And sometimes, you are in clinic and you just want to get some numbers. Oh, what is the median survival, or what is the 5-year DFS rate for this trial, so that you can communicate that number to the patient. In that case, I do read the abstract to get those numbers. But when I'm trying to read a paper for the first time, I usually avoid the abstract and directly jump into the paper. So the first section of the paper will be the introduction, which will tell us the rationale for the study. We are getting back to our Impassion 130 paper. These are all from the same paper, and it says that like chemotherapy is the first-line treatment for triple-negative breast cancer. So it is just giving you the rationale why they did this study. So that might be helpful if you don't know the context. But more importantly, I want to know if there was any prior studies that justified conducting this phase 3. So in order to do a phase 3, probably you should have a phase 2 that showed that this drug is probably efficacious and safe enough to be tested in a phase 3. So that was what I was trying to look in this paper. And I did see that they have mentioned about the safety profile and activity of this drug with combined with nab-paclitaxel, but in a different tumor type, in non-small cell lung cancer. But in this particular tumor type, that is triple-negative breast cancer, it was only a phase 1b study. Ideally, there should have been a phase 2 study with priorly defined success. Like they should have said, okay, we'll do a phase 2, and if the response rate is more than 40%, we'll consider it to be positive and we'll take it to a phase 3. If the response rate is less than that, we'll not take to a phase 3. But that did not happen. And that is a problem that we see too often with new drugs, these Me Too products that are being tested in multiple tumor types at the same time. And this is the last sentence of the introduction. And this sentence tells a lot about the trial. So this is the Impassion 130 trial, which is international trial. That means it is conducted in several countries together, randomized. This will all be explained later in methods as well, but this is a very key sentence. It is a randomized trial. It is a double-blind trial, placebo-controlled in first line. You have the intervention arm, atezolizumab plus nab-paclitaxel. You have the control arm versus placebo plus nab-paclitaxel in patients with locally advanced or metastatic triple-negative breast cancer. So this basically tells you most of the things that you need to know about the methods of this trial. So a couple of things here. It says it's a double-blind placebo-controlled trial. So that can be sometimes confusing. And it can be a little more confusing, especially for the patients, when we say it is double-blind study, this is placebo-controlled trial. Double-blind and placebo-control is important from scientific point of view, but there are also occasions where placebo-controlled trials can be unethical. But basically, I think using a placebo control is important and justified in two scenarios in cancer. One is if we are testing combination, like A plus B, drug A plus drug B versus drug A alone, then to know the added benefit of drug B, it has to be A plus B versus A plus placebo. That's how you can control the trial design well, and you can be more confident about the added benefit of B. So in that case, placebo is important. And also, if the de facto treatment, if the standard of care is no treatment or active surveillance, then in those cases where the standard treatment is no treatment and you are trying to introduce a new drug, then you need to have a placebo control. So having a placebo control automatically does not make the trial unethical. So let's go to methods section of this trial. So this says that patients were eligible to receive chemotherapy, taxane monotherapy, or in the past, because this is a first-line metastatic trial. So if they had received this chemotherapy as an adjuvant setting, then that was okay, but they should not have received any targeted therapy or chemotherapy for the metastatic setting. And radiotherapy was okay. So this just gives us an example of what the patient group would look like that will fit for this trial, and thereby will fit if we use this drug in clinical practice. And then there are also a list of exclusion criteria. What patients will not be allowed to get enrolled into this trial. And these things are important to consider because sometimes like these trials are conducted in a very restricted population and the drug gets approved. But after getting the drug approved, we want to use it for a larger group of population that did not necessarily fit into the trial eligibility criteria. So we do not know whether it will actually work in those group of patients or not. And this is an issue. And that is also more easy to understand if we look into the classic table 1 of the trials, which gives the baseline characteristics of patients. And because this is a breast cancer trial, it's no wonder that female sex constitutes almost 100%. But you can see that there were like at least 3 or 4 people. There were 3 people in the atezolizumab arm and 1 people in the placebo arm who were males. So, and altogether, you have like three males who received atezolizumab in this trial. So if you had a male with triple negative breast cancer, then you could probably at least ask the sponsor what happened to those 3 males and get an idea. And similarly, the other is the ethnic diversity. You can see that Black patients and Native American patients, they were underrepresented in this trial. It's a very small percentage. And similarly, patients with ECOG performance status 2, it's just 1 patient. So this is a problem with stringent eligibility criteria. And actually, we had published a paper many months ago comparing the population diversity in phase 3 trials of cancer drugs with what the US population looks like based on the SEER data. And we know that these phase 3 trials that have led to drug approvals, they have underrepresentation of female patients compared to the same cancer patient population normally, and very few representation of Black patients, and few representation of patients with hepatitis B virus, hepatitis C virus, and especially very few representation of patients with brain metastasis. And so this can be important when you are trying to use the same drug in the routine clinical practice. And actually, ASCO did make a statement saying they want to relax eligibility criteria. They are working with FDA as well, and especially they are trying to make trials more and more inclusive for patients with brain metastasis if it is stable, and trying to relax the age criteria and trying to get more patients with like HIV/AIDS automatically should not be an exclusion criteria, and to allow more patients with more a little more deranged liver function, kidney function also to be included. So that might change in the future, but right now most of the especially registration trials, they are quite strict in terms of the eligibility criteria. So now going to the trial design section, it says that patients were randomly assigned in 1:1 ratio with the use of a permuted block method and an interactive voice wave response system. In randomized trials, it is important to know how the randomization was done, because there can be some ways of randomization that is very prone to bias. Like if we're randomizing people on the basis of, people who, with the name of their alphabets, with the alphabets of the names or date of birth, they are not very good randomization techniques. But nowadays, most of the industry-sponsored trials, they don't face that problem because they use a computer software for randomization, and the software randomly allocates treatment to patients. But if you see that randomization was done by some other means, then that can be a question. And the randomization ratio, 1:1 is the classical randomization technique. Sometimes you will see there is 2:1 randomization, 3:1 randomization. It will be a little difficult to get into the details of that, but 1:1 randomization ratio is supposed to be the best randomization ratio. And then the stratification factors, like when we are randomizing patients to different treatment allocations, then we want to have certain percentage of patients with certain conditions that we routinely see in clinical practice, and that might affect the outcomes. So stratification factors are predetermined. For example, in this trial, they say presence or absence of liver metastasis. So they want to have more or less similar number of patients in each arm who have liver metastasis. And one thing I want to mention here is sometimes you will see that in table 1, sometimes you'll see there is a p-value written here saying that there was no significant difference between the intervention arm and the control arm with regards to certain characteristics. That is very meaningless, because the whole idea of randomization is that the distribution of outcomes will be random between the two arms. So it makes no sense to do a p-testing to check whether there is any difference in these basic characteristics between the two arms. So that is not meaningful. And then continuing with the trial procedure, then they will tell you what the intervention arm was and the dose and schedule that you need for your clinical practice. So atezolizumab was given a dose of 840 milligrams, or patients in the control arm, they got placebo in combination with nab-paclitaxel. So this was every 2 weeks schedule, and nab-paclitaxel was a week, day 1, day 18, day 15, in a 28-day cycle. So this is what will build our regimen cycle. So again, when you are reading this section, the most important question that should come to your mind is the control arm appropriate? So they are combining nab-paclitaxel plus atezolizumab versus nab-paclitaxel plus placebo. So that control arm is getting only nab-paclitaxel. Is that an appropriate control arm? So for triple-negative breast cancer, the first-line treatment, it is chemotherapy, paclitaxel or nab-paclitaxel. So I think it is an appropriate control arm, but not all trials have that. In fact, using some of the trials, they use a control arm that we already know to be inferior. And as discussed before, sometimes they use placebo control when in fact placebo is not justified and ethical. And this paper published in 2019 in JAMA showed that 17% of FDA approved drugs were based on a trial that had used an inferior control arm. To make the point clear, I'll give examples from other trials. For example, this was a trial that tested binimetinib, a new drug, versus dacarbazine in patients with melanoma. So this trial ran from 2013 to 2015, and the control arm patients, these are the patients who have melanoma, they got dacarbazine, which is mind-blowing, because we knew that ipilimumab was the standard of care for these patients in 2011. In 2011, we knew that ipilimumab made a difference. So this trial ran from 2013 to 2015. Like any patient who was not a part of this trial and who did not have problem with the access would have received ipilimumab. But this trial continued to randomize patients to get dacarbazine. So whenever you are reading a trial, the first question is, what is the control arm, and is that control arm appropriate? This is one example of inappropriate control arm where a defeated control arm is being used. The other example is where you use a placebo when active treatment is the default. So in this case, you can see that this is the POLO trial of olaparib in pancreatic cancer, metastatic pancreatic cancer. So these patients got FOLFIRINOX for first 16 weeks, and then they got randomized to receive either olaparib or placebo, despite having a response. These patients were responding to FOLFIRINOX, but their chemo was stopped after 4 months, and then they were randomized to receive placebo. Again, here placebo is not justified. So after deciding that the control arm is okay, then we need to look at the primary endpoint. So what is the primary endpoint of this trial? So for this IMpassion 130 trial, there were 2 primary endpoints. One was investigator-assessed progression-free survival, and the other was overall survival. I'll discuss about PFS and OS, progression-free survival and overall survival, in a minute. But there is something more here. Here it says it was evaluated in both the intention to treat population and PDL1 subgroup population. So the trial has 2 primary endpoints, PFS and OS, and in 2 groups of patients. In the intention to treat patients, and I think you must have been aware of these concepts if you have taken the Masterclass lectures. But the intention to treat population means you are going to assess outcomes in all the patients who have been randomized, whom you had an intent to treat. They might not get treatment later for some other reasons, but they will be included in the analysis. And there is a subgroup of patients that they are particularly interested in, that is the PD-L1 subgroup of patients, because this is a PD-L1 inhibitor drug, and there is a reason to believe that patients who have positive PD-L1 might respond better. So that's the concept here. And the other key point here is investigator-assessed PFS. So there will be two types of PFS, because you need to measure when disease progression happens. So one is the investigator who are treating the patient can themselves decide that, okay, this is disease progression. But the other is an independent body who is blind, and that independent body will take a look at the scans and decide independently that, okay, this is disease progression. And PFS has its own pitfalls, which I'll discuss later. But even between investigator-assessed PFS and independent review PFS, the independent PFS is more reliable because the reviewers are not treating the patients, and so they are not susceptible to the bias that the investigator personally would be. Because if the investigator likes immunotherapy, then even if there is some indications of progression, the investigator might decide, okay, probably this is not progression, and let's continue to treat the patient with the same medication. So such type of bias will not happen if it is an independent review based PFS. So let's talk about surrogate endpoints, because this trial had PFS as one of the primary endpoints. There are a number of surrogate endpoints that we see in oncology: response rate, PFS, time to tumor progression. Disease-free survival is basically PFS in adjuvant setting. Pathological complete response rate and event-free survival, they are relevant in the neoadjuvant setting. And some new endpoints like metastasis-free survival, these are for some limited tumor types like prostate cancer. But the commonest one we'll see is response rate and PFS. So why are we not, as Dr. Hamad mentioned earlier, the most important thing is to improve survival, but why are we not measuring survival in our trials? Because, and why are we using these surrogate endpoints? Because using surrogate endpoints saves time and allows earlier analysis and publication of data. One study showed that compared to using overall survival, if you use response rate, then you can shorten the study duration by 19 months. And if you use progression-free survival, you can shorten the study duration by almost 11 months on average. But what's the problem? Why don't we want to rely on surrogate endpoints then? Because a surrogate, to be trusted, has to be strongly correlated with overall survival or quality of life, the outcomes that actually matter to patients. Patients would probably not care whether the tumor is 2 centimeters or 3 centimeters, as long as it's not symptomatic or as long as it does not mean that they are going to die sooner. So even the FDA says that clinical trials need to prove that the surrogate endpoints can be relied upon. So they should undergo testing. And those surrogate endpoints that have undergone tested are called validated surrogate endpoints. But the problem is, studies show that very few of these surrogate endpoints are actually validated to have a good correlation with overall survival. You can see the blue bar is the highest bar, which shows that which shows a very low which is a proportion of surrogate endpoints in tumor types that has very low correlation with OS. So most of the surrogates have very low correlation with OS, and that's the problem. The other thing is, sometimes we can think that even if PFS does not translate to OS, if we are delaying progression, does not that mean that patient's quality of life has improved? That makes intuitive sense, but actually when we looked into that and when we tested, we found that improving PFS and improving quality of life had very weak correlation again. So delaying progression does not necessarily mean improving quality of life. Again, probably that has to do because increase in size of tumor does not necessarily lead to symptoms, and the drug will also have toxicities which will have a detrimental effect on quality of life. So we're talking about breast cancer. We looked into surrogate endpoints for breast cancer. For breast cancer, particularly, this is what we had found. For this particular paper, we are interested in PFS. So what we had found was, for breast cancer, PFS had only mild to moderate correlation, and it was not sufficient to be considered a valid surrogate for overall survival. So that's what the data tells us. Now, continuing with our study, now we are in the statistical analysis part. So here is something interesting. So what they are planning is, first you can see that what's the number of patients they wanted to recruit. So at first they had a primary endpoint of PFS only. So they plan to recruit 350 patients, but they included overall survival also as a co-primary later on. So they increased the sample size. So now they plan to recruit 900 patients. And the statistical plan was to do analysis of PFS in the intention to treat population first, and then in the PD-L1 positive population. And this is called alpha splitting. Alpha is type 1 error rate. It's usually at 5%. It also gives you your significant p-value. So it's at 0.05, but if you have more than one primary endpoint, you have to split it between the two. So in this case, they gave 0.01 to analysis of PFS and 0.04 to analysis of overall survival. And which means that if you calculate the power is the easiest way to understand is if the trial is positive, what is the chance that our results will also show that it is positive? If the null hypothesis, statistically speaking, if the null hypothesis is false, what is the chance that we are able to show that it is false? That is, if the trial is indeed positive, what is the chance that we will be able to show that it is positive? So for PFS, it was 95%, and for overall survival, it was 88%. Most of the trials, they usually have a power of 80%. The other important thing that I want to highlight here is when they're talking about overall survival, they mention hierarchical testing for overall survival, not for PFS. They don't mention hierarchical testing for PFS, but hierarchical testing for OS. What that means is the OS will be tested first in the intention to treat population. First, they will check for OS benefit in the total population. And then if that is positive, then only they will check the OS in the PD-L1 positive population. So if the intention to treat population shows no OS benefit, then they cannot check that in the PD-L1 positive subgroup. That is a very key point here. And yeah, this also this power also tells us something about what the intention of the trial was to detect the margin of clinical benefit. So if the power is high, then any small margin of benefit can become statistically significant. Like sometimes you will see that everyone must know the famous Canadian erlotinib in pancreatic cancer trial, which showed a benefit of almost 10 days, but it was statistically significant. How that happens is, yes, there is a difference of 10 days. Clinically, it's not meaningful, but because you had enough power in the trial to detect any difference, it turned out to be statistically significant. It might be a little difficult to understand, but basic rule of thumb is if power of the trial is high, even clinically meaningless differences can turn out to be statistically significant differences. So one recent example, we published this paper earlier this year about FDA approval of 2 recent breast cancer drugs, one of which is particularly noteworthy. So I want to cite that. That is the neratinib trial, the phase 3 NALA trial. Here, the median PFS between the intervention arm, neratinib versus lepatinib, was 5.6 versus 5.5 months. This is not a typo. There was actually a difference of only 0.1 month, which is like 3 days difference. But if you look at the p-value, the p-value is indeed significant. The p-value is less than 0.05, and that's why it got FDA approval. But is it meaningful? No. So why did just a 3-day difference turn out to have such a low p-value? Because it was an overpowered trial. The trial had enough power to detect any difference as meaningful. Now we are into the results section. So you can see that this trial was conducted in 41 countries, 246 sites. So this is a multinational trial. And it becomes important sometimes if this trial is conducted in several countries and the standard of care is not uniform across these countries. And PD-L1 positive subgroup was 41%. And this is the classical consort figure. Here, you can sometimes find quite interesting things. Like they at first had 1,235 patients who they wanted to recruit, and 51 declined to participate. And 27 did not have documented triple-negative breast cancer. So even in these high-income countries where this trial was conducted, probably the pathology was not reliable, ultimately 902 underwent randomization. So 451 to receive atezolizumab, 451 to receive placebo. But you can see that 6 patients, they were not, they did not receive this treatment because probably they were not happy about being randomized to placebo. That's an immunotherapy bias that you see. They accepted the trial because they thought they were going to receive immunotherapy, but they did not. So they did not consent to this. And 7 of them, in fact, they moved from the placebo arm to the atezolizumab arm. So when we say intention to treat, we have to include all these 902 people, 451, because this was the original intent to treat. This is the randomized population. But when we say safety population, because we are looking at adverse effects only on patients who got the drug, so we look at the safety population includes only those patients who received at least 1 dose of the drug. But for those patients who did not get even a single dose, we do not include them in the safety population. Now, going to results, of course, the Kaplan-Meier graphs are the most important parts of the results. You will see that this is what they told they would do in the statistical analysis. They said that PFS is one primary endpoint. So this is the results for the PFS. They said they are going to see PFS in ITT population, intention to treat, and then in the PD-L1 positive population. So that is what they did. In the ITT population, it was 1.7 months benefit in PFS, which was significant. If they looked at PD-L1 only, it was 2.5, a little more impressive. 2.5 months benefit in PFS. Again, this was significant. But then this is the OS, which is the second endpoint. If you look at OS, the p-value is 0.08, which is not significant. And if you remember, what they had told us in the statistical analysis was if this is OS will be tested in a hierarchical design. That is, if the OS in the ITT is positive, then only we'll check OS in the PD-L1. If OS in ITT is negative, we won't check OS in the PD-L1. So this is negative. So they can't check OS in the PD-L1 subgroup. But yeah, this is what they had said, hierarchical testing. But they wanted to rescue this failed trial. So they wanted to rescue it somehow, and they said they would not do it, but they did it. They did check for OS in the PD-L1 positive subgroup, although the OS was already negative in the ITT. And here they found that there was almost 10 months difference in median OS. And they later claimed that this is important. But because this violated the statistical principle, this could very well be a false positive signal. So this is just an exploratory analysis which violated their own statistical plan. They should not have done this, done OS analysis in the PD-L1 positive subgroup population, but nevertheless they did. And then they say that because of the hierarchical statistical procedure, formal testing was not conducted. Nevertheless, we did do that, and we found that it was 25 months versus 15.5 months. And based on that data, actually FDA approved this drug for triple-negative breast cancer with positive PD-L1. And we'll talk about it in a while. But whenever we see that there is PFS positive, but OS is negative, one of the commonest questions people think about is, what about the subsequent therapy, or was there crossover? Crossover means if the placebo arm, control arm patients got the intervention at the time of disease progression, then probably that could have diluted OS effect. So one of the commonest questions you can think of, if there is positive PFS but negative OS, is crossover the reason for no OS benefit? And the thing is, you'll not find any word about crossover in this publication. So you need to look into the supplementary material. In the supplementary material, if you go into the protocol, then you will find that they have specifically mentioned no crossover was allowed. Now, is this a good thing or a bad thing? It depends. if this atezolizumab, if this new drug was already approved in subsequent lines, then crossover should be mandated because we cannot deprive patients of an effective therapy. But as in this case, atezolizumab was not proven in any line, so not allowing crossover is actually good. And if crossover is taken care of, then you need to see about the subsequent anti-cancer therapies. Were they balanced between the two groups, or one group was penalized by not getting standard of care subsequent anti-cancer therapies? In our trial, it was balanced between the two groups. I will probably not have time to discuss about crossover issues in detail, but let's talk about subgroup analysis. This is from our IMPASSION 130 trial. There is nothing much here to look at, but I just want to discuss how to think about subgroup analysis. You will see these forest plots in several trials that have conducted subgroup analysis. And one way to think about subgroup is one, if you are doing multiple subgroup analysis, you have to control for the false positive rate. So you have to see whether the p-value has been controlled or adjusted or not. Second, you have to see if someone is claiming subgroup difference, what the p-value is for the interaction. Sometimes they will give you the p-value for the interaction. And the other rule of thumb is you draw a vertical line like this from the overall hazard ratio. And if other confidence intervals are touching this vertical line, then subgroup differences are not very meaningful. Like in this particular trial, there is not significant subgroup differences between patients with regards to outcomes. One important example is this classical phase 3 trial in non-small cell lung cancer, cisplatin gemcitabine and cisplatin pemetrexed. And if you want to know more about this, we had written this paper discussing the subgroup analysis in this trial, but this is the bottom line. So this trial showed that here you can see in squamous cell carcinoma, gemcitabine seems to be better, and in adenocarcinoma, pemetrexed seems to be better. And they also provide the p-value 0.03 and 0.05, and it looks significant, and this has changed practice. But that vertical line that I was talking about, if you run a vertical line from all patients, then actually all the subgroups touch this vertical line. So there should not be much of a difference here, except for this squamous cell carcinoma line. And the other thing is there were 19 subgroups here. And if there are 19 subgroups, you have to control for p-value accordingly. You have to divide 0.05 by 19. And that would be your significance level. And this paper clearly says that p-values were not adjusted for multiple comparisons. So this does not tell us that the subgroups are actually that different with regards to outcomes. So if you had corrected the p-value, then to claim significance, the p-value should have been less than 0.0026. And these both p-values are higher than that. So these are not significant differences. Now we are coming to harm section. So this is the table for key adverse events. Actually, I would love to see a more detailed adverse event table, but something of interest, like how you look at this is if there is something that particularly interests you, like nab-paclitaxel, you would know that neuropathy might be a problem. So you want to see if aiding atezolizumab escalates this, which does seem to be the case. And then you might want to see for some immune-related toxicities, because this is an immunotherapy. Hypothyroidism seems to be an issue here. And the other thing is I'm particularly interested in fatal adverse events. How many people die from side effects alone? That is an important metric. And in this case, it seems to be 1.3% versus 0.7%. And they will also tell you what they consider to be related to the drug. For example, 3 deaths in the atezolizumab group were considered to be related to drug, and that was the case of autoimmune hepatitis, mucosal inflammation, and septic shock. And most of the trials, they also give you serious adverse event data. This trial did not, so that was disappointing. This trial actually did not use any of these words, but we need to be careful because some of the trials just say that the side effects were acceptable or manageable or tolerable. That does not mean anything. We should actually look into the toxicity data. And this trial also did not give us any information about quality of life, which is important. And this actually seems to be a common issue with many other trials as well. But we need to be suspicious of trial that does not provide quality of life information. And actually some studies show that it can be several years until you have quality of life data from these trials. And finally, we go to discussion. Like after assessing all that, or after analyzing all that methods and results, there is in fact no need for reading discussion, because discussion is just the interpretation of the trial. And as I mentioned, the industry is interpreting the trial. I read them sometimes to discover the extent of bias that can be there, or sometimes for my own research. But you can also read discussion just to know how the authors have interpreted the trial, but do not trust the discussion. In discussion, sometimes you'll see the signs of the work of the professional medical writers. Like in this particular trial, there were some interesting statements. It says, although it was not statistically significant and formal testing could not be done, but still there was some numerical increase in median OS. And it was by 10 months, but again, it was not statistically tested, and numerically higher response rate. And despite all that limitations, it says this trial establishes this as the standard of care. And I find this funny. No new adverse event signals were observed. If some new adverse event signals appeared in a phase 3 trial, I would be a little concerned and surprised. This is about the discussion. What about the editorial? Sometimes some of these major trials also come alongside an editorial. I like to read the editorial to know how other people who are not authors of the trial interpreted the data, and whether that interpretation was congruent with my interpretation or not. But again, you should check the conflict of interest of the editorialists as well, because most of the editorialists also have significant conflict of interest with the same industry who is making the drug. And we had done a recent research which showed that if the editorialist was getting conflict of interest from the same industry, then they were more likely to write an unduly favorable editorial. So that's the reading of the paper. What's the verdict? Do you think this is a wonderful drug and we should be using it? I guess we don't have the capacity to take any responses from the audience, but as I showed, the FDA gave accelerated approval to this drug based on this trial, and so they had to run another trial to confirm benefit, and that was the Impassion 131 trial. And when they ran the trial again, this time with paclitaxel combo, they found that even PFS was not improved, 5.7 versus 6. And if you look at OS, there is actually a signal of harm here. The hazard ratio is 1.11. Median 22 months with atezolizumab versus 28 months without atezolizumab. So whatever we saw in Impassion 130, that they violated the statistical principle and they ran subgroup analysis in PDL1, whatever we saw was a false positive. That was not a true positive. But even in this paper, you'll see that they write explaining this, saying that these findings may result from imbalances in prognostic features or chance findings in a relatively small trial. This is not true. You can say that this is not true because it can't be a chance finding in a relatively small trial, because if you look at the absolute numbers, the numbers are, this is not about statistical significance. The numbers itself is less in the atezolizumab arm versus the placebo arm. So this is not about chance statistical, like lack of statistical significance. And again, if you want to read in detail about this controversy between these two trials, so we had published this paper in JAMA Oncology. But the verdict is that after that negative confirmatory trial, now the FDA actually had to withdraw the approval for this drug in this setting. So that's all I'm going to discuss today. We need to have enough time for the breakout rooms as well. But these are some of the other topics that are important, but I did not have time to discuss today, like early stopping of trials, non-inferiority design trials, and the role of censoring. But we discussed about a lot of problems with these trials. But if you want to get an example of a good trial that was properly done, then I'd recommend reading this trial. This is the ESTOP regimen for temozolomide in glioblastoma. And I think this is a trial that is really well done and really well reported, which we may be able to discuss in future iterations of the masterclass. But again, if you have not gone through the masterclass, I highly recommend that you go through it. And yeah, happy to chat with everyone in the breakout session. Thank you.